get a lot of good information into your hands throughout the year. So we'll be watching over the next several months as we have these opportunities actually on a monthly basis for the next 4 months. We are excited to be able to continue offering these opportunities and actually have extended out where we're offering these to all the regions across the state. So if you're coming from another region, thank you for joining us today. And if you're not a current Northeast FEHIMA member, we'd love to have you join us. Current membership signups are valid through June 30th of next year. So we've had an extended year. So absolutely take advantage of it because all of the webinars are free to members and our student members as well. So before we get started here, let's go kind of cover a few housekeeping rules. I have muted everybody just to keep background noise down in information. I do believe that covers if you should put us on hold, but if you have to and you have background music, try to avoid that if at all possible, putting on hold for that. If you're not actually on the web today and you're only signed into the phone part of the webinar, please be sure to email me to let me know that you have attended because your name doesn't always appear on the phone dial-in. So if you're not sure, let me know. CEUs are sent out based on attendance. So I'm going by the list of everybody that's here. As you've noticed in the registration process, we've had some change in how we register our webinar events to be more efficient for the organization. So once this is over, we'll compile our information, send out a survey link to you, as well as a copy of your CEU form to the email address that you registered with the new service on. And lastly, if you have any questions during the webinar, please feel free to type your questions in the text box in the chat area, and we'll address your questions during the Q&A session. So on that note, we want to welcome again everybody and welcome our speaker, Kim Davis-Allen, who's actually a returning speaker to Northeast FEHIMA. We really appreciate that. Kim has served as an outreach coordinator for Florida's EHR incentive program since the program launched in 2011. She works closely with provider practices throughout the state, conducting educational and outreach activities on program requirements, best practices, and practical applications. Kim also works closely with Florida's other health information technology initiatives, including the Florida Health Information Exchange, helping providers understand the various programs' overlap and support of each other. And Kim has over 35 years of Medicaid experience with an emphasis on program development and education. And today, Kim is presenting to us on the Medicaid Incentive Program and in the changes that are going forward, as it is now going to be known as promoting interoperability. And I hope that that we all have a chance to hear some of the new information about the final rule overhaul that I believe was actually published last Friday in the Federal Register. So, Kim, I'm going to turn it over to you, and please share with us.
Great, and thank you for having me back. I don't know, we try to come and talk to the local groups as much as possible because we know that you're the ones who are actually on the ground using this information, getting this information out to others. So we always do welcome any possibility to come out and interact with your membership. So, but saying all that, I want to do the classic bait and switch. So I got you all here to talk about EHR, but I do want to take just a few minutes and talk about some of our HIE services. And the reason is that for some of our services, we do have funding available to our Medicaid providers that I want to be sure that you're aware of, because as you take it back to your organizations, the services we're offering may be something that is a benefit to you. Some of you may already be participating in them, but because there is the funding opportunity, any opportunity that we get, we want to make sure that providers know that there is some resources to help them adopt and integrate some of these additional services. So I'm just going to take a few minutes, talk about this, and then we'll come back and talk about the EHR incentive program. So for those of you who are familiar with the Florida HIE, we do kind of have a new look. The HIE has actually been around since 2011, back when the EHR incentive program actually began too. But over the last year, we've kind of looked at our services, revamped our look, and really tried to, streamline what we are offering to those things that are really helping providers be more interoperable, be able to share patient information, and not only share the information, but get the information that they need for their patients as well. When we talk about Florida HIE services, we're really talking about a lot of different things. We talk about some e-prescribing initiatives. We talk about telehealth, it's always a big topic. Well, of course, we talk about EHR because that's the foundational piece for a lot of the things that we want to do. But we have 3 primary services under the Florida HIE. The first is our query exchange. For those of you who may have been kind of keeping up with the HIE over the years, we used to have a statewide infrastructure that participants could sign on to be able to share the patient information directly back and forth. And that was kind of like I said, a statewide infrastructure. What we realized is that there was already a lot of local infrastructures as well as a national infrastructure. And what we were doing was just really putting another layer in there. So we've kind of backed off from the statewide infrastructure, and we're really promoting connectivity either at the local basis or at the National eHealth Exchange. So basically what happens with a National eHealth Exchange is it has the standards, it has the certifications, your system should be able to link into it, and it just really allows you to share information with anyone else who may also be on the National Exchange. This is what a lot of people think of as typical, traditional health information exchange. I'm taking my patient record, sending it to somebody else, or vice versa, you're out there looking for information. We do not have, the eHealth Exchange does not have any kind of repository, so it really is a direct provider-to-provider connection. It just kind of facilitates that by having those certain standards in place that allows that information to flow more freely. If it is something that you're interested in, we can definitely connect you, but it also helps you support meaningful use requirements by being able to exchange those summary of care records. Looking ahead for stage 3, there's going to be a requirement that not only do you share out your information when you're transitioning a patient, but that you're also consuming information from those patients coming into your system of care as well. In addition to the standard medication reconciliation now, stage 3 is requiring that you also consume and put as part of your EHR system the information as those patients transition into you. So Query Exchange is something out there that can help you with that. We also have a direct messaging service. Now, all of your systems, being certified systems, should have the capability to do direct messaging. And we'll talk a little bit more about direct messaging and secure messaging and transitions of care when we get into the EHR portion. But for those providers who, for whatever reason, are not using the system built into their EHR, we do have a standalone service that we offer, offered through Apriva. It's very reasonable. It's less than like maybe $200 a year, unlimited mailboxes, but it really allows you to be able to take the information out of your system and share it with other providers. The good thing about direct messaging is that it's not limited just to physicians' offices. Ancillary type providers can also sign on to this service. So if you have a lot of patients transitioning to assisted living, nursing homes, therapists, direct messaging is a really good way of being able to send that patient information. And then again, of course, it also helps you meet the meaningful use requirements by having a mechanism to send those summary of care records. We are a direct trust accredited system. That means that we are able to share information with anybody else who is also part of the direct trust accreditation process. So even as your patients transition from state to state, if everyone is on the same direct trust and have the same accreditation standards, those messagings can be sent back and forth. But the thing that I really wanted to talk about was our event notification service. This is kind of the thing that is really taking off, and as I work with other states as well and find out what they're doing, this is the kind of one piece of information that we hear that people need, that physicians need. Patients are going to the emergency room, they're getting admitted and discharged from the hospital, and that information doesn't always flow freely back to the primary care physician. The event notification service takes that admit, discharge, and transfer information from the hospitals and can send it back to the primary care physician of record. So what happens is as patients move through the hospital system, that information is then relayed back to whoever has subscribed to information on that patient. Currently, we have over 215 hospitals connected, representing about 95% of acute care beds. It can be real-time. It can be a batch process. There's lots of different ways this information can get back to you. And not only does it do inpatient admissions and discharges, but it also captures the emergency room information as well. So again, your patient may have gone to the emergency room over the weekend. For whatever reason, you're never notified about it, but then 2 or 3 days later, they end up in your office for the very same reason. If you're seeing a lot of Medicare patients, this also gives you that mechanism to be able to get that patient back in the office and bill that transitional care management fee, so there can be a real high return on investment. This is just kind of some case studies from organizations that are already subscribing to the service. Let me see if I can move this. Yeah, some organizations that are already subscribing to the service. This is being really readily used by ACOs, managed care plans. All the Medicaid managed care plans are subscribing to this information. And like I said, we do now have funding to connect direct providers into getting this information as well. That funding will cover the first year of your participation fees, and then for the second and third year, there's some specialized pricing that is being worked out so that you can continue for the service. So again, it's something I want to make sure that you're aware of. If it's something that you think that you say, hey, this may be something that's really good for my organization, I'll have the contact information at the end of today's webinar, and you can follow up with that. But the money's out there. We have funding to the end of this fiscal year, and I believe there's going to be some additional funding for next year as well. Well, it's making progress. There you go. One of the other benefits of the event notification service, and this is kind of an add-on, there's no additional cost for this, is that you can have what they call prompt, proactive management of patient transactions. It's just basically a web-based interface so that as that information is coming back to you, and like I said, you can get it in a variety of ways, but one of the ways is to get it through the prompt interface, and it allows you a care management component so that you can kind of track patients as they move through your system as well. As you can see, Jared here has been to the emergency room a couple of different times, so that you'll see that all kind of captured in one location. It also allows you, as over here on the left-hand side, as it kind of gives you a queue of patients so that, you know, Terry, who's going to work with Terry, who's going to work with Stephen, that sort of thing. So again, if you don't have a care management process in place, this is just something that is at no additional cost that allows you to be able to track patients. As you get the information through the ENS feed, you can kind of track them within your system to figure out who's going to work with them, what needs to be done with them, and then just kind of have that overall picture of patients who may be frequent flyers to the emergency room or regular admissions to the hospital. Okay. Another thing that I wanted to mention that you may or may not be aware of is an Empower program that is currently operational in Florida. It is not a specific state HIE program. It is actually a federally funded program. But Empower is taking the Medicare claims data and helping identify those patients at risk that may be at risk during some sort of emergency. This just talks about the patients that quickly were identified in anticipation of Hurricane Matthew. I'm sorry, I'm coming in tongue-tied. In anticipation of Hurricane Matthew, they used the Empower data to identify the at-risk population, and then did a reverse lookup of their phone numbers. So they called 40,000 different residents to say, hey, hurricane's coming. Are you ready? Do you have what you need? 169 of those actually said, hey, yeah, I'm going to need some additional assistance. So out of the 40,000, 17,000 actually responded to the call, and then 169 said, hey, yeah, I really want to do something out of the 7 counties in the current program. The reason I think this is important is we're looking, you know, hurricane season. You never know when a natural disaster may happen, just really significant rainfall. Currently, it is using Medicare information, but they are looking at being able to also use Medicaid information as well. So again, just taking the opportunity to let you know some of the cool things that are out there that are helping your patients. Okay, so let's get to the heart of the matter. That was a lot of information in just a few minutes. So yes, promoting interoperability. So we've had the EHR incentive program since 2010. We actually launched our program in September of 2011. But as part of really trying to align programs across Medicare and Medicaid and implementation of the new quality payment program, CMS has come up with the new term of promoting interoperability. So you'll see that. It's still the EHR incentive program. Even though it does align the two programs in terms of reporting, it doesn't really change what each program requires in and of itself. So we also like to talk of it as, do you have got MU? Because that's still where we are in the program. Providers are having to attest to meaningful use in order to continue participation. Okay, I'm going to turn this other computer off, the buzzing. Okay. All right, so just a couple of EHR fun facts. This is a lot more fun if I'm in person when we talk about this, but these are just things that are really interesting. You know, the EHRs have been around really since 1960s, and they started in the Mayo Clinic. And over time, they have definitely evolved. They've even really evolved since the program first began in 2011, which really encouraged a lot more adoption of systems, certified systems. Since 2008, the adoption of an EHR by an office-based physician has nearly doubled. I don't think that's any surprise. I think what would be very interesting is to figure out just how well used these systems are. I think in the early days of the EHR incentive program, everybody got a system, but how well do they use it? That's definitely changing because of some of the other things that are going on as well. This one is very troubling. About 45% of providers report spending more than $100,000 on an EHR. And we hear that time and time again. And when you look at the payment through the incentive program, even cumulative over the 6 years of participation, that doesn't come nearly close to $100,000. But it is a start. And the whole intent was to get kind of providers past that hump of getting a system in and getting it adopted and getting staff trained on it. We are seeing a lot of providers who are now in the rip and replace. Maybe they bought a system, it's not really working for them. Maybe some of the features aren't there. Maybe the customer service is not there. I hear that a lot. But we do have about half of our providers now looking at replacing the systems that they had in place in previous years. So just kind of interesting facts and figures about that. I don't think it's any surprise. Epic, Medicaid, and Cerner are our big hitters. Even in the state of Florida, we routinely go through all of our applications and find out what systems are being used primarily. And these are the top three for Florida as well. So promoting interoperability, we've already talked a little bit about that. Again, the purpose was to continue CMS's focus on improving patient access to health information and reducing the cost and time, the time and cost required of providers to comply with program requirements. Now, that's a lofty goal. There's still a lot of requirements. It's still very time-consuming in order to be able to collect the information to actually do the application. But I am hopeful that what is being required, the meaningful use requirements, are now just becoming a way of doing business. That providers are just doing CPOE, providers are just doing annually their security risk assessment, and we're moving away from I'm doing this because I have to do it for meaningful use to I'm doing this because this is just a good practice within my office. And even more so, this is a good practice in my office, and it really is kind of helping support the patient experience and the provider's workflow. So some of the key points of the program, and this is, kind of definitely changes, is Stage 3 meaningful use is now going to be required in 2019. There's no indication that they're going to back off of that. It originally was scheduled to become required. Stage 3 was going to be required in 2018, but again, they've changed it now to 2019. They were considering doing a scoring methodology that was proposed in the original Promoting Interoperability rule. That was pretty much shot down from Medicaid. Medicare is complicated enough through the quality payment program and having to have some sort of scoring methodology, but I don't think any state said, hey, yeah, we think it's a really good idea for the Medicaid. ECQMs comes and goes, they change, they add new ones, they take away new ones, and of course the reporting periods for both meaningful use and CQMs is, I think, of great importance to everyone, and we'll cover what those are going to be in the coming years. Just to let you know, on program year 2017, we actually just wrapped up making the last payments for program year 2016. We ended up making 2,128 payments for program year 2016 applications, which is down a little bit, not significantly from years past. For program year 2017, this is just kind of the breakdown of the applications that we've received. These numbers fluctuate because some applications get approved, some applications get denied, so the actual years of participation may change a little bit when all is said and done for program year 2017. What I think is interesting is year 6. For every year for the last 2 years, we've had about 250 providers who have been at year 6 for the program. So that's really telling that providers are definitely coming back. Year 1, you'll notice there's no more because 2016 was the last year that someone could begin program participation. And we still periodically get that question. In 2016, we had over 600 year 1 applications. So hopefully everybody who could potentially get in got in. But we get the question still today, well, I have a new provider, can they participate? The answer to that is no. Unless they have received a payment for program year 2016 or earlier, they cannot now begin the program. One thing I do want to caution you, though, is if you have new providers who may have been at other practices or other states, they may have received payments through those entities and those organizations. So if it's somebody who has been practicing, who's coming into your office, you might just want to check to see if they have received a payment either through another entity or another state. But if you have a new resident or someone who's never, been practicing, then the answer is going to be no. They're not going to be able to participate. This just kind of gives you a sense overall of how many people across the nation, as well in Florida, have been participating in the program. Even though Medicare's EHR incentive program has now ended, they still have some wrap-up applications. What I think is very telling, when we started the program here in Florida, we anticipated about 4,500 unique providers. And as you can see, we have definitely more than doubled that goal. So again, we're glad, money's out there. We need to make sure that people get it out. And we've made close to 16,000 payments, or over 16,000 payments, and these numbers are a little dated as well. So we'll definitely continue that. As I said, I think the numbers for 2017 were down a little bit, and I think as we get into later years of the program, we won't have the total number of applications, which will, for each year, just because providers kind of come and go. The measures get a little bit harder, the requirements get a little bit stronger, but we're going to be doing everything that we can to help providers be successful attesters. We're going to be doing all the targeted outreach for those providers who may have attested way back when and have never come back. And then we're going to be looking at continued resources for those providers who are trying to, come back every single year, because we do know some of the measures are rather hard to meet. All right, so these are some more little fun facts and figures. You can only talk about meaningful use so much. And as a survey, you can find a survey to support just about whatever you want it to say, but this was one that I thought was really interesting. Like I said, a lot of providers got EHRs because they had to, so they could check the box and get their incentive payment. But over time, we see the trend that the use of the EHR is just becoming that way of business. It's just the thing that you do. And this survey indicated that 71% of providers felt that their EHR had improved e-prescribing. So that's good. E-prescribing is very important. 38% made it easier to exchange patient health information with other providers. Again, that's good. We still have a lot of providers who cannot meet the health information exchange requirements. They have trouble finding other providers who are willing to accept it. But at least the trend is there that some of our providers, and this is not Florida specific, are able to find that their EHR is facilitating that process. So this is what meaningful use, modified stage 2 and stage 3. We did just wrap up 2016, as I stated. We're in the process of processing all of the 2017 applications, so there's no more accepting of 2017 applications. So of course we're looking ahead for program year 2018, and even further ahead for 2019 through 2021. The question we get a lot too is the program going to end early? No, there's no indication the program is going to end early, so it will continue through 2021. So we have about 18, 19, 20, 24, 4 more years of participation for our providers. In program year 2018, providers can still attest to modified stage 2. Nothing really changed there. Or they can go ahead and attest to stage 3 if they have a system that is certified either through a combination of 2014 and 2015 certification standards to meet the requirements. I don't think we're going to see a lot of stage 3 over the course of the summer. When I've asked providers, I think I've only had one who indicated that they might be moving on to stage 3, but I think most providers will stick with stage 2. And we encourage you to do that. It's something you've already done. It's a little bit easier to meet, and it's a little more self-explanatory. So e-prescribing is one of the components of modified stage 2. I'm not going to go over each of the measures specifically unless you'll have a question, but I want to talk about how some of the other things that are happening in the state kind of support e-prescribing. So we monitor as part of the HIE, or I guess as part of the agency overall oversight, we do monitor e-prescribing rates. It's been something that we're doing for a long time. E-prescribing is something back in the early 2000s. We had specific grant money to encourage participation, and what we have found that over time, pharmacies are readily easy or readily accepting of e-prescriptions, but we really had more trouble on the physician side. And there were a lot of reasons. Not all of them had systems that could do e-prescriptions. There was an additional cost to the provider when they did e-prescriptions. But like most things, we're beginning to see that trend shift upwards. And the e-prescribing rates have definitely gone up, as you can see here. So we've increased from about 1.6% in 2007, it's hard to say 2007, up to close to 81% in 2018. And this is Florida specific. This is just kind of some more information about the Florida e-prescribe averages. So here's all the licensed prescribers. Almost half, we can round up, almost half, about 48% are actually doing e-prescriptions. And then the other thing that has really become of note with the opioid crisis and definitely with the new legislation that has passed is how many providers are prescribing controlled substances. Now, when you're looking at the meaningful use measures, you have the option of whether or not you include controlled substances, and because there's additional steps that have to be taken on both the pharmacy's part and the prescriber's part, we don't see that being included a lot, but it is your option on the e-prescribing meaningful use measure as to whether or not you include controlled substances. Just be consistent that you include them in both your numerator and your denominator if you do include them or exclude them. But overall, we think it's really interesting to see that the number of those providers either prescribing or pharmacies accepting definitely is increasing as well. Now, pharmacies has always been high, as you can see. There's always been a lot of pharmacies who can accept controlled substances e-prescriptions, but the number of the providers actually doing it has been relatively low. But it is increasing. In 2017, there was 8% of electronic prescribing of controlled substances enabled providers. So we're really watching that. And I think you'll see too with some of the new legislation and some of the requirements, that number is going to go even higher over the next couple of years. One of the requirements of meaningful use is that you do have to do the specialized registry, tying back into e-prescribing and prescribing of controlled substances is our E-FORSCE. E-FORSCE is the prescription drug monitoring database. It is the keeper of all information on controlled substances, either by the dispenser, being the provider, or the pharmacy, based on the prescriptions written. E-FORSCE has been a really good, viable solution for our providers as a specialized registry requirement as it relates to meaningful use in e-prescribing. With the new legislation that went into effect in July, there was definitely some changes. E-FORSCE underwent some changes themselves, as well as how providers get into the information. So I think it's really important that if you were someone who was using E-FORSCE as your specialized registry requirement, that you make sure that you're kind of familiar with what those changes are, if you're not already. For those who don't know what E-FORSCE is or what the Prescription Drug Monitoring Program is, it's just basically that collection of that information. It is used a lot by enforcement agencies. AHCA uses it in monitoring both people who are getting controlled substances as well as prescribers who are prescribing controlled substances. And, you know, the whole intent is that that information may not really be available to someone otherwise. So here it is, you know, patients who may not come in and tell you all the time that, yes, I have pain medication prescriptions from all of these different providers or that type of thing. Emergency rooms can go out there and access it as patients come in seeking treatment as well. It can tie back into the EMS services as well. So if you have someone who you see a trend for going into the emergency room for pain-related issues, you know, seeing what's going on in the hospital, seeing what's going on with the PDMP, it just kind of all ties together what's going on with that patient. Just some characteristics about the PDMP are also known as E-FORSCE. It contains over 232 million records. Wow, that's a lot. The number of prescriptions per patient, and again, remember, this is controlled substances. This is not all prescription. This is just controlled substances is 5.08, and the number of prescriptions per prescriber is close to 179. So it's really good statistics, really good way of monitoring the issue. Because of the new legislation, new House Bill 21, like I said, they definitely had to undergo some changes. They really had to beef up their resources. The number of active users definitely changed. So all of this is to let you know that if this was something that you were using, something that you're thinking that you want to use, go out there, do your research, and make sure you understand not only what the new legislation requires for the prescribing of controlled substances, but on the back end, how E-FORSCE can help you meet the meaningful use requirements and just give you really good information about your patients as well. For those providers who are using E-FORSCE as their specialized registry requirement, there are new documentation requirements for program year 2018. When I say new documentation requirements, I think because of E-FORSCE underwent some changes, what you see and what we see is going to change. There is still the requirement that you have at least one patient query during your EHR reporting period. Now, again, because of the new legislation, all prescriptions for controlled substances have to be bounced up against E-FORSCE before you can actually do the prescribing. So we definitely see those numbers go up quite a bit for 2018. But in terms of meeting meaningful use, we're still looking for that one query. It could be there, you could use the report that there's a copy of here on the screen, or you could take a screenshot of the information that you get back from them. Be sure to redact any kind of PHI, and that can be your documentation. Also, because there have been some changes at E-FORSCE, some providers are having trouble getting the information back out of it. So if you've already decided your EHR reporting period for 2018 and you're using E-FORSCE, go ahead and run your query. Go ahead and take that screenshot just so that you don't run into problems on the back end when you're trying to get that information out of that. Like I said, screenshot may be the easiest thing during your EHR reporting period. Look up a patient, take a screenshot, clean it up, and put it in your documentation file. Okay. So we always want to talk about our challenging measures. Now, out of the 10, they could all be rather challenging for modified stage 2, but these are the 3 that we really hear the most from our providers, either through our webinars or our phone calls or being out in the community, that are creating the most problems. And I will say it's not unique to Florida. This is across the state. We were at a CMS meeting back in June, and consistently every state there said health information exchange, getting providers to accept those electronic transmissions is an issue, and getting patients to sign onto their patient portals is an issue. So let's talk about some of the things that we've learned that could be helpful in this area. This is, again, a survey. So this is areas where providers have identified that there's definitely gaps in information exchange when they're moving patients between healthcare systems. Testing always kind of rises to the top. Maybe there wasn't complete information about a test or a procedure, or you didn't have good medical information. but about 32% of the providers who did respond to this particular survey said that one of these things had to be redone because the information was not there. So again, looking at the query exchange, that national eHealth exchange, the transition of care requirement through meaningful use, a lot of these, or all of these, can kind of help bridge that information gap and make sure that that total patient record goes from provider to provider. So the health information change requirement is that you create that summary of care record, also known as a CCD, but it can also be a PDF, electronically through your system. And excuse me, that you're able to create the summary of care record through your system, and for more than 10% of those patients transitioning out of your care, you have to send it electronically. Now that's where direct messaging comes in, that's where the query exchange comes in. You cannot directly fax it from point A to point B. There are some intermediary fax type situations that do apply, but again, you have to figure out how to get it from your system to that other provider electronically. Now, you may not have a problem with it. You may be able to meet all of this. You may be able to produce it, get ready to send it. But what we find out is that there's nobody on the receiving end. That's where the direct messaging can also come into play. The system that we specifically offer, and other systems may do this as well, you both don't have to be on the same email system. If you send it out of your system to the direct messaging component, it can alert their regular Gmail, AOL account, whatever, say, hey, you have a secure message, go out there and look at it. That meets the requirement on your end, and then they'll have to go out there and look at it and pull down the information for their patient record. If you have less than 100 patients during your EHR reporting period, then you can exclude from this measure. So, again, what we hear is, finding out who I can send it to electronically. Some of the tips, some of the things that we've taken from you, your responses, is go ahead and identify your referral sources. And instead of trying to send it electronically to everybody who you might send a referral to, find the 2 or 3 that are more willing to work with you and really concentrate on those numbers. Depending on your denominator, this may be relatively easy to meet if you kind of focus your efforts. A lot of times providers are not totally aware of how their system calculates it. So again, make sure you know what your system is doing. So we had a provider that they weren't checking a specific box when they were being able to create it and send it out. So therefore, at the end of their EHR reporting period, it looked like they were not meeting the measure, when in fact they just had failed to click a specific box within their system. Figure out how you're going to send it. Again, you may have a system within your own system to be able to send this information out, or you may have to look at some standalone systems. And then the most important thing, and this is true for all of the meaningful use measure, is really kind of stay on top of what your numbers are. We encourage providers to run their numbers all the time, and we have some very successful offices at the beginning of every week. They just run their reports, kind of do a touch base to see where they are, what they may need to tweak that week. That may be, a little much for your office. You might want to do it every 2 weeks or monthly or whatever, but don't wait till the end of what you think you want your EHR reporting period to be and realize that you're not meeting these particular measures. I've had several of those providers as well. Patient electronic access, I'm going to have to talk a lot faster because I'm running out of time. This is the patient portal. All over the board on this. So basically, more than 50% of your patients have to have access. That one has definitely gotten better over time. I think providers have figured out how to make sure everybody at least has the information to access it. The flip side is more than 5% of patients actually have to do something with it. And again, wherever I go, I have a group who is all over the patient portal. The next day, nobody wants to use the patient portal. So a lot of it has to go back with how the provider's office really promotes it. It's really interesting when you look at the surveys. Again, a survey is a survey. How many people have accessed their EHR? This is the patient portal. It says like 44%. But when we talk to our providers, getting even to that 5% has been a real issue. I'm going to flip through these. I think it's really interesting, though, looking for a healthcare provider is the #1 reason people have used a computer or smartphone or electronic means. Everybody uses TripAdvisor, depending on if you get to travel. Everybody's using those phones to find resources. So patient electronic access, make sure you know how your portal works. Within your own office, make sure everybody is promoting it. Gimmicks work. We've got some provider offices that are very creative. One said 1 day a week, they really focus on patient portal usage. You know, kind of like going back to your HIE referrals. 1 day a week, they really focus on making sure everybody who comes into that office that particular day is using their portal, looking at their portal, knows how to get to their portal. And the other 4 days of the week, you know, hope that the information is definitely available, but it's just not the focus. And again, know how your system is calculating those numbers. Patient privacy and security. This is one issue that we hear that a lot of patients are concerned about patient portal and they don't want their information out there. But as you can see, it's been pretty stagnant. You know, I think it comes and goes, data breaches. Oh, there's a big data breach in the news, so I'm really concerned about my health information. Then it kind of goes back to everyone being more accepting of it. Secure messaging. So this is that mechanism that not only does the patient have to have ability to access their patient portal, 5% of them have to do something with it, and then an additional 5% have to be sent a message by the provider's office. So what we see typically here is I send a message to my doctor and the doctor responds. The doctor's response is what counts. Really encouraging use of that patient portal, making that the primary way of communicating for certain things within your office has proven very successful for other practices. Suggested uses, probably the biggest thing is requesting prescription refills and referrals. You know, hey, go into your patient portal, tell us back in the summer from a provider's office, and they said they just really, I don't want to say they didn't give patients the option of calling in for certain things, but it just kind of became the normal way of communicating with the physician's office was through the patient portal. And it's a little troublesome at first, you know, it's a little different for everybody, but then it really did kind of help facilitate communication back to the patient, had those written records of communication back to the patient, as well as improve some of the workflows within the provider's office as well. So patient portal is just something, it's definitely out there, it's not going away, so you just have to figure out what's the best workflow within your office. So let's look at stage 3 meaningful use. The thing with stage 3 meaningful use is it's not so much changing what has to be done, it's just how it's kind of capturing what has to be done. So, and they're all very patient driven. So if you quickly back, well, what they've done in stage 3 is they've taken 2 or 3 of the same measure and put them under one heading. So in this particular case, this is your access, patient access to health information. So you have to do with 50% now, it goes up to 80%, but then you can also include the use of an API. There's an app for that. And incorporated with this one is the patient education resources. You know, currently it's 10% of patients have to be provided educational resources under modified stage 2. That requirement goes up to 35% now. And in order to meet the patient electronic access to health information requirement, you have to meet both of these under stage 3. View, download, transmit, as well as educational information. Coordination of care. So you have to attest to all 3 of these, but you only have to meet 2 of them. So not only does the patient have to have access to it, now 25% of them have to be doing something with it. So again, just kind of keep that in mind. Those numbers definitely go up. 35% of patients are sent a secure messaging, though go ahead, spoiler alert, there is proposal to change these percentages. So just kind of focus on what the requirement is, that patients still have to be able, you still have to send patients secure messaging. And then the third one that's creating, I think, the most angst for providers is that the incorporation of patient-generated health data from a non-clinical setting. So it could be your Fitbit, it could be your in-home blood pressure monitoring. So all 3 of these have to be reported, 2 have to be met in order to meet the 1 measure of coordination of care. And then, of course, the third one that's going to be, I think, an issue is the health information exchange. So where is it? Now it goes up to 50% of the summary of care records have to be sent electronically. 40% of those that are coming into your system of care, now you have to consume their information from another provider. So right now it's only measuring what's going out. Stage 3 is measuring not only what's going out, but what's coming in. And then the third one is doing a clinical reconciliation of those patients coming into your system of care. So a lot of emphasis is still going to be on health information exchange and patient engagement and looking at stage 3. Public health reporting is going to be, I wouldn't say problematic. I think providers are just going to have to spend a little time figuring out what are the 2 of the 5 that they're going to meet. What's going to be a burden on the state and then CMS as well is really defining the difference between a specialized registry, a public health registry, and a clinical data registry. So we're kind of doing our due diligence on our side, making sure we understand what CMS is proposing, getting that with CMS, and then we'll be releasing some additional information on exactly what resources are available here in Florida for stage 3 in 2018. Now again, stage 3 is not going to be required, so that's good. But even, as you know, even now at the beginning, you need to be preparing for 2019 when stage 3 is actually going to be required. So let me talk a little bit about the rule changes, which is all of that to get to this point. So in the rule that was just finalized, it did not change anything for the meaningful use requirements. Now, there's a lot of confusion because it did change some of the stuff on the Medicare side and for hospitals, but as far as those 10 modified stage 2 measures that you have to report in 2018, they did not change. Requirements are the same, thresholds are the same. What it did do specifically to the Meaningful Use Program is it solidified a 90-day reporting period for 2019 and 2020, which is good. So going into it, you know that instead of having to attest for the full year, you're going to have that flexibility to find that 90-day reporting period that for which you're meeting the measures. It also gives you the flexibility that, hey, I'm not meeting it now, let me try again, let me try again, let me try again, which is going to be a real issue if we ever go to full year reporting, because at the end of the year, if you're not meeting it, then you're out of luck. It doesn't change the CQM reporting requirements. Currently, if you're the first-time meaningful user, you only have to report CQMs for 90 days. Everybody else has to report it for the full 365 days. That's going to be problematic. I mean, your EHR reporting period is only 90 days, but your CQM reporting period is the full 365 days. So if you're a returning meaningful user, the earliest you could attest, even for program year 2018, is going to be January the 1st. Proposed changes in the, these are the proposed changes for like 2019. So these are just proposed. Nothing's been, nothing's been done. One of the things for CQMs is they're going to require states to have what they call at least one high priority measure. So my understanding of that is that Florida would say, okay, everybody has to report on this one particular CQM. It could be that the provider says, this is the one that I want to use, so we may kind of have a laundry list. But these are just being proposed, so we haven't, spent a lot of time looking at that. Under Objective 6, that coordination of care that I just went over very briefly, it was set to raise from 5% to 10% for 2019. They're going to keep it at 5%. So that'll really be good. And that's where a lot of providers are having that issue of being able to exchange that patient information. So if they keep it at the 5%, then kind of it'll keep us, being able to meet that particular measure. On the secure messaging, it was set to rise to 25%. They're also proposing to keep it at 5%. So again, I think what CMS has recognized is that it's been a little bit harder for providers to be able to get, when they're being judged on outside actions, they don't have as much control. So I think they're recognizing that they need to keep these thresholds low enough so that providers can still continue the activity, but not be penalized when they can't meet these higher thresholds. The other thing is on public health reporting. This is not really specific in Florida on syndromic surveillance, because the way that syndromic surveillance is up in Florida is it is only restricted to urgent care settings But in other states, anybody can report syndrome and surveillance, and CMS had restrictions, so they are proposing to remove those restrictions. So again, these are proposed changes. This is the rule that just came out for public comment. We're definitely going to comment that, hey, we like these. And so I'm hoping by the time 2019, providers really start planning for 2019 and thinking about and putting into place their systems and workflows, that we'll have some solidification of what these proposed changes may be. I think I've talked a little bit about program year 2018. We are looking at potentially opening the system in December. Because most of our providers are going to be returning meaningful users, we don't want to open the system too early because most of them will have to report the 365-day CQMs. We also are working really diligently to clean out 2017. If you've been participating in years past, a lot of times we'll have an overlap. We'll still have outstanding applications from the previous program year. Providers can't really attest for the new program year. But this processing staff is really working diligently to get those cleaned up. If you have an outstanding program year 2017 application and you're working to get additional information or wherever you are in that process, I encourage you to do that sooner rather than later. Like I said, we're really trying to get those cleaned up. We don't want you to be caught in a situation of having a hard deadline of getting something in and missing that and missing out on the opportunity for a payment. Again, providers can attest to modified stage 2 or stage 3. And 90 days for first-time meaningful users for CQMs. Everybody else has to attest for the full year of CQMs. I don't think CMS is going to back down on that in the next couple of years, at least 2019, but we are proposing that in 2020 and definitely 2021 to then look at a shorter CQM period. We can hope. Just a couple of the new patient engagement initiatives. Blue Button has actually been around a while. It's for Medicare. It's CMS's attempt at letting patients control their information. So information is fed into a single or a unified patient portal known as Blue Button, and then the patient can go in and share that information with whoever they want to. The My Healthy Data is similar to that. Instead of having multiple patient portals and sources of patient information, that all of that information is kind of collected into a centralized place, and then the patient can say, hey, I'm going to Dr. A today. Dr. A, I want to give you access to this information. I'm going to Dr. B tomorrow, that type of thing. And so that it really puts the patient more in control of their information. And then, again, part of the national conversation is that it's the patient's information. The patient should really control where it goes. And then that kind of cuts down some of the policy barriers between organizations and entities and states, and even the states and the Fed. Said this before, if you are looking at a testing for meaningful use, go ahead and start running your numbers if you're not already. Know where you stand, know what you need to work on, look for additional resources to help you meet the specific measures you may not be meeting, and then it also gives you time to work with your vendor if you think you're doing something and for some reason the reports are not reflecting that. Here's all of our contact information, all of our resources. You want more about e-prescribing or e-FORSCE or Florida HIE as well. We have some great information on the work we did on telehealth over the last year that may have been real interest to you too, depending on where you're practicing, what services you're offering. There's a lot of nuances with telehealth, but we are beginning to see some traction on that as well. Okay, that's a lot of information, a lot of fast talking. So we do have a few minutes for questions.
Does anybody have any questions?
I will get these slides to you, and you can get them sent out.
That's perfect, Tim. I think that's probably one of the biggest questions that everybody always has is, can we get the slides?
Yeah,
so
we'll get these slides to you.
Okay. If there's no other questions or anything else like that, I don't see anything popping up in chat. Okay. If there's no questions, we can go ahead and wrap up today. Kim, we really appreciate the information that you put there. It's good to know, though, that, I mean, even as they change that name and go to Improving Interoperability there, it's certainly easy to understand where that's coming from. But we definitely, definitely appreciate knowing that there's been some slack given on that. that. So thank you very much for sharing all that information today.
Yeah, and one thing too, just I know that we all, myself included, every time they release a rule, it's like, oh my goodness, oh my goodness. And I think CMS is finally recognizing that people have not been able to meet meaningful use, meet these thresholds, meet these requirements as quickly as they thought. You know, if you remember back in the days, it was going to be stage 1 for 2 years, stage 2 for 2 years, and then stage 3 for 2 years. And I think CMS is recognizing that providers are doing everything that they need to do. They're just not being able to meet some of these higher thresholds. So hopefully, as they do make changes to the program, it'll be in recognition of provider efforts and not just these kind of lofty goals that we've seen in the past.
Well, that's absolutely great, and good to see them coming around that way. So, and if there's no questions or any thoughts or comments, if you have anything on the back end, feel free to email me, and I'll get your questions and messages out to Kim. Kim, we really appreciate, again, your time.
Well, thank you for the opportunity.
All right. Everybody have a great day, and thank you for joining us today.
Mm-hmm.